Assalamu alaikum. So our group 7 will be talking about dosimetry of intracavitary Brachtherapy. So this is our group members and my name is Siti Najla. So I'll be talking about the importance of dosimetry of intracavitary brachytherapy. So the first one is standardization and quality assurance, where the appropriate dosimetry is necessary to lower the possibility of improper administration and to provide accuracy and uniformity in dosage measurements across various treatment facilities, and these facilities should be traceable through primary and secondary dosimetry laboratories so that patient safety, treatment effectiveness and overall quality of brachytherapy can be assessed. And the second one is precise tumor targeting to reduce the chance of recurrence and improve overall survival by increasing the dose at the tumor site with preserving healthy surrounding components.
Next, we will discuss about technical aspects of intracavitary brachytherapy. In this part, we will cover about the selection of the applicator, the imaging guidance, the source loading, radioisotopes used in the treatment planning system. In intravasitary brachytherapy in HPUSM, the commonly used applicator in tandem and ovoid, which consist of one tandem that will be placed in uterus and two ovoids would be put in vaginal fornices. Meanwhile, the single cylindrical shape applicator that is placed in uterus with a radioactive source positioned along the central axis. The selection of the applicator is based of size and tumor location in order to delivering an optimal radiation dose to the tumor while minimizing dose to surrounding normal tissues. Imaging modalities play important roles in image-guided brachytherapy, especially in treatment planning and dose calculation. CT image provide 3D reconstruction of applicator and surrounding anatomy, while ultrasound mainly used for insertion guidance of applicator and aids in avoiding perforation. For source loading, we can choose either using manual technique or remote afterloader machine. Nowadays, using machine was better to minimize radiation exposure to staff, especially when using HDR source. Two common radioisotopes are cesium-137 for low-dose rate brachytherapy and iridium-192 for high-dose rate brachytherapy. Both can be used for cervical therapy, but commonly now, iridium is better choice when using remote afterloader. Lastly, treatment planning system, TPS, is a software that helps design, calculate, and optimize the radiation dose delivered to the tumor while protecting healthy tissues.
Intracavitary brachytherapy using a vaginal cylinder is frequently used to treat endometrial cancer after surgery, particularly to avoid recurrence at the vaginal cuff following hysterectomy. The objective is to provide a high dosage of radiation to the vaginal wall while shielding organs such as the bladder and rectum. Before treatment, the patient empties her bladder and lays in the lithotomy posture. A smooth plastic cylinder, 2.5 to 3.5 centimeters broad, is placed into the vagina. The location is then checked using a CT scan. Using a treatment planning system, TPS, we design the radiation dosage surrounding the cylinder using iridium-192 and adhere to TG43 international criteria. The dosage is provided for either the surface or 0.5 centimeters deep. Finally, the therapy is administered via a remote afterloader, with the session typically lasting 5 to 10 minutes. It's safe, effective, and patients may usually go home immediately away. I will explain about dose specification for intracavitary. Before this, we used ICRU-38 for dose specification for intracavitary. Due to lack of the information, ICRU-38 was replaced with ICRU-89. ICRU-89 emphasized 3D image-guided planning. There are three types of dose we need to consider, which is dose to OR, dose to IR-CTV, dose to IR-CTV. Dose to OR included is less than or equal to 90 grays EQD2cc. Rectum and sigmoid is less than or equal to 75 grays EQD2cc. Dose to IR-CTV includes macroscopic tumor, cervix at BT, whole cervix, residual disease, tumor still present in the perimetria. Tolerance limit is greater than or equal to 85 grays. Next, last the tumor as it was at the time of diagnosis, which is greater than or equal to 60 grays. Why we take a 2cc, D2cc? Because it gives a realistic, reproducible, and clinically meaningful measurement of the maximum dose an organ at risk receives. It's now the standard metric in 3D brachytherapy planning to assess toxicity risk.